I'm Ahmina Akhtar. I'll be hosting today's session. So I'm a registered social worker and I'm the head of Equality, Diversity and Inclusion at Social Work England, the specialist regulator for social workers in England. I'm also a member of the RSPH Council and I'm really delighted to be hosting today's event. We'll be exploring co-production and patient voice within public health, and as a social worker, championing the voices of those with lived experience. Advocating and campaigning have always been central in my work. So really looking forward to exploring some of these concepts here today. There's no single formula for co-production, but there are some key features that are present in co-production, and I look forward to exploring these and patient voice with you today. So one of the reasons we've started late is that one of our guests, Dr. Navina Evans, is having a few issues with the technology, but I'll do some introductions for her and Charlotte before we start, and then we'll start with Charlotte, and hopefully there won't be too many issues as we go forward with the tech, but one of the challenges of obviously working remotely. So Charlotte, who will start, is the Chief Executive of National Voices, a coalition of 160 health and social care charities. She holds a PhD in law and medical ethics. Charlotte has held senior positions in health and research policy in Parliament for national regulators and in the charitable sector. Since starting at National Voices, Charlotte has led strategic reorientation of the organisation towards a more visible voice for members' insight, practice and innovations, and towards grounding national voices influencing work more explicitly in the experience of people who live with ill health, disability or impairment. National Voices seeks to strengthen the voice of patients, service users, carers, their families and the voluntary organisations that work for them. And then hopefully we'll also have Navina shortly, so I'll still do an introduction for her. So Dr. Navina Evans is the Chief Executive of Health Education England. Navina joined HEE in 2020 from East London NHS Foundation Trust, where she's been Chief Executive since 2016. She has over 20 years of clinical experience in psychiatry, medicine and paediatrics, and previously held the positions of Deputy Chief Executive and Director of Operations. Navina has worked as the Clinical Director for Children and Adolescent Mental Health Services, CAMS. She has also been involved in medical education at Barts and the London Medical School as honorary senior lecturer, associate dean, and provided pastoral care to medical students. Navina is passionate about staff wellbeing and co-production with patients and advocating for the best possible care and creating a culture of enjoying work for staff. I'm also delighted to say that tech issues have been resolved and I believe she is able to join us. So hopefully you'll hear from her soon. But I'm going to start with Rachel. So over to you, Rachel, and I believe you're going to share your screen as well.
I think you mean Charlotte.
Oh, sorry, Charlotte. Apologies.
Right, let me share my screen. Right, can you see that? Cool. Right, as Ahmina said, thanks for the introduction. I'm Charlotte. I lead National Voices. We've actually got 180 members now. It's growing massively. During the pandemic, we've really managed to step up our engagement and have a growing membership. Some of those are the really large ones you will have heard of: the British Heart Foundation, Alzheimer's Society, Diabetes UK. And then there's a lot in the middle that you will have only heard of, maybe if you have like a specific condition or someone you love has a specific condition. And then we have a lot of members also who are very small organizations under £100,000 have free membership. So, you know, we have volunteer-led organizations and so on. So together, we think we have a lot of insight in what people need and also in how one could meet those needs innovatively and creatively. We say our mission is to democratize, humanize and equalize health. And that we understand that as not just being about healthcare, but about being health more widely. I'm here to talk to you about why it's worth listening to people. And I thought maybe I'll start with an actual quote from someone who talked to National Voices. So we set up a platform called Our COVID Voices at the start of the pandemic. It's now closed, but you can still read the testimonials. People with substantial health and care needs were encouraged to go on this platform and tell their stories about what their lives are like as the first lockdown was being implemented. And this is the sort of stuff we heard. And if you work in public health or care, I don't believe this will surprise you. People have had a pretty rotten time. And people have told us, and we've also done quantitative work on the data that our members have collected, because a lot of our members have surveyed people. So we did a quantitative piece of work analysing over 66,000 responses to surveys. We are very confident with our claim that people's mental and physical health has massively deteriorated during the pandemic. And that should leave us always pause for thought as to how we're going to turn that round. And I would start from the assumption that more business as usual isn't going to hack it. So I hope you've had a chance to read these words. I find them still quite distressing, even though I've read them a number of times. So let me start with a little drawing I found some time ago on Twitter and thought, oh my God, this sums it up so nicely. Why do we actually want to hear perspectives of communities? I purposefully here don't speak of patients, because I think, we're having a conversation about public health and we should make out people live their lives as patients. They don't. They live their lives as people and communities. So what you can see here, for those of you who might not be able to see that so well or can't make sense of it, is a couple who are leaning over a cot for their baby, and they're admiring their baby toy, which is hanging over the cot, and it's like 4 different kinds of animals, and it's lovely to look at. And the baby, the second picture is the baby looking up at this toy, and all the baby can see is bums, and it's not really very obvious what the purpose is of looking at 4 different bums. So it's obviously a riff on user-led design and user-led perspectives. But if we kind of transfer this argument to public health or population health management, or whichever way you want to frame the work you're engaged in, who do we design population health management systems for? What does it feel like to be at the receiving end of population health management system? Are people even aware that such a thing exists? What's the first thing they hear about when a wise population health manager reaches out to them? I'm always a bit worried that these systems have been designed behind closed doors based on quantitative data the health service holds, which is not representative of people's experiences of health or ill health. It is about transactions with the health system, which are very unequal, and that the first thing a community will hear about this new approach the NHS is now adopting is that they will be told that they're at an elevated risk of diabetes, or that they should really lower their cholesterol levels, and that they're just going to scratch their head and go, what's all of this, and why should this matter to us, and when is anyone going to ask us what really feels like ill health around here? So the question, what matters to you, is the one that doesn't just need to shape the relationship between a doctor and a patient, or a health professional and a patient. It needs to shape the relationship between the public health system and communities. What matters to these communities? And if we design the public health system or population health management system bearing that in mind, we probably wouldn't end up just looking up at bums. We would put the interesting bits of the toy, because at the end of the day, this is designed to entertain the baby so that the baby can actually see it. Another statistic I talk a lot about, and again, it won't surprise any of you. You will have probably seen this if you've been to any health conferences in the last 10 years. This is just for diabetes, but it's not going to be different for many other chronic conditions. Health systems and places where healthcare is delivered is not where people's lives take place, and it's probably not where health or ill health are created. So I don't think I need to convince an audience largely consisting of public health professionals of this, but it's always worth reminding NHS colleagues of that. No matter how wonderful that interaction of a diabetologist is with the patient, in that time it is a patient, whether this person fares well with their diabetes or not is largely determined by stuff that happens outside the hospital or outside the consultation room. And how come the health system is so curiously uncurious about that life? So how come we just say to a patient, you have poor control, which diabetes patients over and over say is really upsetting them. And we don't seem to be curious about the fact that they might not be able to feed their children during the school holidays, or that they have no food preparation skills, or that they're holding down 3 jobs, or that they're living with domestic violence. How come we don't try to surface the context in which someone's health or ill health is being created? So going back to the listening exercise we at National Voices did during the first wave of the pandemic, we worked with a social researcher who went through the first 50 testimonials we collected on this platform. And she found that these are the main things people want to talk about. And you will see that only the 6th level of responses is about what the health system actually does. And all the others are about other concerns. And again, if you think about what the last 18 months have been like, our inability or otherwise to contact health services has obviously been a cause of stress, but other things have been very determining of our experience, not least as to whether we're on a 0-hour contract, or whether we can get furloughed, or whether we have a garden, or whether our children have access to digital devices and can take part in school and so on. So one of the questions I've been asked by the organisers of this event is if I can explain a little bit about what co-production actually is. And I thought I'd start that by sort of why we need it, because that's really the more important point. So just then briefly, the principles of co-production. I think these capture it quite well. I think far too often we treat people as the problem. And we confuse the fact that they might have a problem with the fact that they are a problem. And we don't build on people's insight that will help develop a solution to this particular problem. Essentially, a commitment to co-production is based on an understanding that people who are the closest to a problem are also very well placed to come up with a solution for it. Not necessarily on their own, they might need other knowledge, they might need other input, they might need support, but we can't solve it over their heads, essentially. And if we try to do so, we are going to build very expensive, very ineffective health and care responses to problems that often cannot be resolved without people co-producing the solutions. Good co-production will have these sort of characteristics, treating people as assets. I think it's worth pausing on the sort of another assumption that underpins good co-production is that we have different kinds of knowledge and different kinds of expertise that we need to contribute, that each knowledge and each expertise isn't all-encompassing and universal, so that a clinician understands how raised cholesterol contributes to heart attacks, and a manager understands how we need to organize heart failure services, but people understand what they need in order to get active, or what they need in order to change how they eat. And that none of those knowledges on their own will solve the problem of, I don't know, raised blood pressure, raised cholesterol, and high levels of heart failure in certain communities. I think the vaccination program is a really good example. And my sense is that the vaccination program has been one of those learning moments where people deep in the bowels of the health system have begun to realize that the snazziest biotech response, and what an impressive response it is. You know, I don't want to at all diminish how wonderful it is that the biomedical model has got us to effective vaccines really quickly, but it cannot get to people on its own. And for certain communities, it needed Ali, who drives the minivan for the mosque, to actually get it to people. And his knowledge is as important as the knowledge of the person who's developed the vaccine, ultimately, if we want an equitable delivery of this program. So I always think it's worth pausing on this respect for different knowledges. Ahmina said before we went live, can you say something briefly about the sort of layers or kind of qualities of co-production? I think it's hard to do it any better than our members at NSUN have done it. I very much encourage you to have a look at this report. I firmly believe we need to stop reinventing the wheel. We need to stop coming up with yet more categories and jargon around this. They have set out really clearly, and you can find it on their website, it's a network of user-led organizations in the mental health space, what's required to do this really well, the kind of principle, the purpose, the processes, and how you then measure impact of good co-production. It's, you know, suitably conceptual and suitably practical. Just to sort of log the thought that there is a profound difference between thinking you know what needs to be done and testing that with people. And there's nothing dishonorable about that, but it's not co-production. And actually sitting down with communities and trying to get to a good definition of the problem you're trying to resolve together, and then developing solutions together. That's the whole co-production kind of level that we need to, for the wicked problems we're facing, we need to try to do that, because we have tried, we think this might work, can we just quickly test that? We've tried that approach quite a lot, and it doesn't seem to work on some of the really thorny issues around inequalities, around the interface between the medical and the non-medical, around the interface between mental and physical health. We need to do better. Right, what does this mean for public health? I think it means something about, and I've started talking about that a little earlier, interfacing quantitative data sets with insight that communities own. So often the quantitative data set points to the fact that in this community, we have a higher level of, 3 more minutes? We have a higher level of a prevalence of a certain condition. But the why question, the why is this happening in this community, and the how are we going to do something about this, can only be answered by combining this quantitative insight with insight into lives lived by people. And I think the communities are entitled to that technical knowledge. There's nothing wrong with making people aware of the fact that they might have a highly elevated risk of diabetes, but the why question is not going to be stuck in your spreadsheet. So I think there's something around data and insight. And in order to make that work, we need to embrace the role of the advocate. I think far too often people inside the health system, and I include the public health system in that, want to reach straight to communities, very marginalized communities, seldom heard voices, and they sort of disregard the role of the advocate, that these communities often have organized themselves, and they often have people who know something about these communities, and that you need to work with those people as intermediaries, as bridging people. You are not going to hear from Somali women who've experienced FGM just by sending them a survey. You need to work with people who know those communities well and have got something to contribute. And that means they need to be in the room, they need to help you shape the question you want answering. I think there's something also where co-production often goes wrong, is that the people inside the system, because they hear problems, and often quite dire problems from communities, then get drawn into trying to promise that they can solve everything. And that's why I put this bullet on here on acknowledging uncertainty and a lack of power. So if you consult your community on what needs to be done so that they can use their local park better, there are a lot of things you won't be able to change. You can't change that this is an A road. You can't change that, I don't know what, you know, you can't change there's not enough workforce. You can't change that your hospital needs a massive capital investment and it's not going to happen. So I think it's really important that when we ask communities to place their trust into the dialogue you're trying to set up, that you don't promise the world, that you're really clear about what it is you have and don't have inside your control. And then connected to that, also acknowledge that you're often talking to people who have far less power than you. Your power is limited. You are a professional. You're doing a job for a system. other people's power is far smaller and far more limited. And they're at constant risk of exclusion, and it's really important that that's reflected in how we engage with them. And then finally, I wish we could kind of capture as a public health outcome that you might end up holding the phone number of someone in a different sector, in a different part of your borough. That is really important stuff. That's stuff we need to hold on to, that you can call the woman who runs the Somali Women's Association and say, can I just run something past you? And that is something we need to invest energy in, and that will yield results in the end. So I hope that wasn't all a bit too frazzled and unclear, but do let me know what your questions and thoughts are on all of this, and I'm really looking forward to hearing how this conversation unfolds. Thank you.
Thank you, Charlotte. And we could spend so much more time talking about everything that you've said, but obviously, given that we've not got long, it's been a really good overview, and hopefully there will be some questions that people can ask using the chat. So thank you once again. And it's great that you've been able to join us, Navina. So I've already done your introduction, so I'm going to hand straight over to you in the interest of time.
Thank you so much. Can you hear me?
Yes.
All right. Yes, great. Okay, so technical hitches, a bit of a panic there. Now I'm going to try and share my screen. If that goes, well, that will be fantastic. I think you can see my screen?
Not yet.
No? Oh.
Not yet.
Oh, now what have I done wrong?
You need to click on the thing you want to share and then click on share.
Okay, that is what I've tried to do. Let me end the show and try again. Click on the thing I want to share. Hang on. Here we are. And then share. Is that coming up?
Yes.
Perfect. But is it coming up as a slideshow? Here we are. Yes. Yay. Look at me, aren't I clever? Right, thank you everybody for inviting me. I think I've got about 10 minutes or so, just over. Yeah, excellent, okay. I grab every opportunity to talk about co-production and the patient voice. It's something that's really important to me. And what I hope to bring is my kind of real life experience of why it mattered and how important it is. And then what we are trying to do at Health Education England to advance this in a kind of slow but steady and a really important piece of work. So my name is Navina, Chief Executive at Health Education England. I've been there since October of last year, and before that I was a Chief Executive at a provider organisation in the NHS. I'm also a child and adolescent psychiatrist, a clinician, and so I have a long history of working in health and care. I wanted to start by sharing with you why it absolutely matters to me. From a personal point of view, I think it matters to me as a clinician, as a leader and a manager, and also as a patient and a citizen. I will start with what I think is the least important bit of why it matters to me, and end on the third point, which is the most important part. Throughout my clinical career, I have really benefited from the wisdom of the people whom I serve and the people who I work with. And they are not just the patients I came across, but also their family members, their friends, their relatives, their communities. I worked in child and adolescent health and then mental health. So inevitably, you're working with a group of individuals or a system. And so that became really powerful to me. Also, I think if you work in mental health, the voice of the service user and the carer and the family has quite an important role. We have a history, not always a very happy relationship, but a really important one. And the voice of patients and service users have been really critical in informing our work. Personally, I can tell you hundreds of stories about where the impact that listening to patients, listening to family members, listening to friends made such a difference, not only for their outcome, but also for the outcome of my team, for other patients, for the services that I worked in. So if we have time, maybe some of those stories I would love to bring out as well. So it matters to me as a clinician. I think I was more effective, I was more efficient, and I was more productive as a clinician because of the input and listening to our patients really carefully. As a leader and a manager, so I then went into management and became a chief executive of an organization. It was East London NHS Foundation Trust, where I can't take the credit for it beginning, but I'm very proud of the work that we did in terms of working in partnership with patients and carers. And I think we went through the whole journey of it starting as patient involvement, feedback, and then it became what we called people participation. And we were really taking that over many years to a level where I think at East London Foundation Trust, they would say they're working towards co-production. I don't think anybody would say that they were truly practicing co-production, but it is certainly something that is part of the end point that they want to get to. I can tell you that as an organization, we embedded service user involvement, participation, and then working towards co-production in so many ways that was really helpful, right from the informal through to proper processes, through to proper support, right the way through to impact and influence on the board, the strategy, and the way in which the organization worked. And I can honestly say that that influence really made a huge difference to the lives of our staff, our service users, and also to the outputs and outcomes for the organization as a whole. I want to just say three key things that really mattered to us and what made the difference. One was when we formalized the arrangements for proper co-production and participation with the people who use our services. And as we moved into general practice, we had much more formal and meaningful engagement with communities. And I think meaningful engagement is something that's really important to talk about. And I think that meant one example is there's a formal subcommittee of the board. It was a board committee, which was the People Participation Committee, which helped to set the strategy and the work plan for the year for the organization. And as chief executive, I was in attendance at that committee. We were held to account by the people we serve properly. And that's separate from governors and members. The other thing I would say is that in Elft, they had a process of quality improvement, and patients and service users were very active. They were trained and they were part of the teams that delivered quality improvement. They were also part of recruitment of all staff. I'll leave that behind now and talk about myself. I am a service user myself. I have multiple long-term conditions. And so I use services right the way from primary care to specialist secondary care, pharmacy, etc. And one of the things that is really interesting to me as a healthcare professional, a leader in the healthcare system, and someone who uses services is how separate the two seem to be. It's really interesting. So as a service user, I've got plenty to say, and I know how hard it is. I can talk to you for hours about how my own experience and journey can have an impact on how things can change. So I know what it feels like, and I really want to make sure that I do my bit to help actually use the voice of the service user. Now, having said that, I then want to talk about why actually in the NHS and in health and care, it is a critical part of what we do. From time to time when I struggle, I keep going back to the NHS Constitution. I think this is a marvelous thing to remind ourselves of what we're here for. And it's so clearly embedded in the Constitution about actually that first pillar there, working together for patients. It should really say with patients, I think now. And the commitment to quality of care, respect and dignity, compassion, improving lives, everyone counts. This is our NHS as people who use the NHS. All of those pillars, I can't see how we can't have the voice of and co-production with your consumer, customer, service user, the person who pays us. That's what we need to be thinking about. I just want to say a few words before the end about Health Education England. Some of you might not know that Health Education England is an organisation that really we have a remarkable privilege of shaping the healthcare workforce of now, current, and way into the future, right across the whole of the health spectrum. So I think we have a really, really important part to play in listening and making sure we reflect the voice of the patient or the service user, the citizen, the communities who we serve. And when it comes to public health, we are talking about good health, well-being, as well as illness. So it's really important to listen, to think with people about what keeps people well. Here I have for you just some of the information, the work that HEE has done to actually think about how we plan for the workforce and how we set out our strategy and deliver the mandate that is ours to do the work we do in order to develop the workforce for the NHS and beyond. And so in HEE, over the last couple of years, I think it's been, I only joined in October, we've actually finally got to having the voice of people. Used to be called the Patient Advisory Forum. It's now the People's Advisory Forum, where we have tried to bring together a group of really helpful and committed individuals from across England who are either service users themselves, patients, carers, people who are trainees and students, to try to embed and be involved in shaping what HEE does, and how we then shape what happens in training and learning for the professionals who will then go out and serve people in the NHS and in our communities. So actually our ambition is to have the voice and to have co-production at the start of our business that actually helps us to produce at the end the person that goes back and closes the loop by serving the people who put us here to do the job in the first place. So it's quite a big ambition for us in HEE, and I'm really pleased to be able to share that with you today. And I'd really love to hear people's thoughts about how we can do this. I finally want to end with just a reflection for the number of years in which I have personally been involved in working with people whom I serve to deliver care. It's a movement, and that's what for me is really important. Like-minded people gradually chipping away and listening. I notice in the questions that I'd love to talk about how we can make this something that's more consistent, and it's not as hard to do as we imagine that it could be. Thank you. I'll stop there.
Lovely, thank you, Navina. And there are a few questions in the chat, and we've also got some previously collated as well. So I think there's quite a few that we'll try and get through in the short period of time that we've got today. Shall we start with the one that you said that you'd already seen? Do you want to remind me which one that is? Because I've just been collating a few, and then start with that.
Okay. Can you still hear me? I think there was one. And have I stopped sharing my screen?
Not yet.
Oh, how
so
do I
yeah,
do
it'd be
that?
great if you could do that. So there should be a stop sharing.
Oh, here we go. Where is it? Is it on the? Look at me.
It's at the top of the screen, right at the top.
Yeah.
There's a little red thing that says stop sharing, I think.
Yep, got it.
There you go.
Have I done it? Yes.
Yeah,
perfect.
You have.
See?
Yes.
Thank you. So I think the question I was looking at was the one that said, what are your thoughts? Oh, no, hang on. Key tips for creating environments, tracking learning and measuring the impact on co-production and processes.
Yes.
Yeah, that one I was caught by my eye. Yeah.
Okay, I can repeat that one. So that's what, just to remind everybody. So what are your key tips for creating environments, tracking, learning and measuring the impact of co-production processes? So if I start with you, as that one caught your eye, Navina, and then Charlotte, you've got a couple of minutes to process.
Yeah, so for me, and I'm just going to be speaking from my experience in service, but also my experience now in HEE, it's about hearts and minds of professionals. And I think I made the point that we sometimes when we come to work as professionals, we leave the person, the human, behind somewhere, I don't know where, at the door. And I think it's really about making the case and demonstrating that actually this makes everybody's lives easier. It's really good for everyone. The second thing I'd say is some of us are afraid of demonstrating to people who use our services that maybe there's things that aren't right, or that there's things that can be improved, or we get things wrong sometimes, and we're afraid to say that. And the remarkable thing that I found was that actually service users, patients, carers really want to help us make things better. So it's okay to say, you know, this isn't great, this isn't working. And you are the one that knows how to tell us how to fix it. That's what I'd say.
I mean, there's a lot I could say, but let me just limit myself maybe to one point in particular. I feel too often when decision makers say, oh, we need to hear from the community about this, they sort of pretend the question's never asked before, and they start from scratch. And I think where that, at the sharp end of inequalities, that can actually feel really extractive. I think we keep asking communities we're not serving very well about how hard it is for them to use services. And that, you know, that cannot be justified, you know, forever. We need to at one point move towards solutions. So my plea would be to create an environment that actually values co-production and values the user and the community voice very strongly, is make yourself aware of what we know already. So there is a patient experience library. They do a literature search for you for a very small amount of money. And they go through all the great literature. They go through everything, any health watchers ever published, any AGKs ever published, any carers organizations ever published. They can synthesize all that insight for you. And then you will know what question you still need to ask. You will ask a more intelligent question, a more specific one, rather than describe to us what your problems are. I've just recently been made aware the NHS in the Northwest is commissioning a project they call the 1,000 Voices Project, and they want to hear from 1,000 people about their experiences of living through COVID. You know, it's an honourable ambition. There's nothing wrong with the ambition, but I'm slightly despaired because between us and a whole load of other organisations, we have documented those experiences. The Centre for Mental Health, us, Mind, loads of disability charities. We have thousands of people's experiences written down, synthesized and analysed. We do not need to find another 1,000 people in the Northwest to say the same thing, that it's been hard for young people, it's been hard for disabled people, it's been hard for people who are alone, it's been hard for people who have dementia. We know that. Can we move on to solutions? I think the constant going back to the from scratch engagement actually devalues the status of the knowledge we're generating.
Thank you both. And I think that links quite well to another question that somebody's asked, which is, what are your thoughts on co-commissioning across many siloed pillars around health? So I feel like you've covered a little bit of that, but I think there might be a bit more to build on, but I think there was an overlap. So I thought it'd be helpful to ask that.
I'll just start that and then hand it over to Navina. The problem that fits into one of the silos the system has built is yet to be invented. So if you just break your arm, maybe you manage to stay within the confines of the silo that the NHS has built for you. But if you need some rehab afterwards in order to regain functionality of your arm, you're already into the problems the silos create. So any real life problem requires the input of more than one state player and of more than one community player. This is just the reality of how problems actually pan out. And I think there are really good examples of good co-commissioning to make that work in practice. So I'm, for example, aware of one of our members, Rethink Mental Illness, in the lead in a really innovative commissioning consortium in Somerset. People with severe mental health are held in the community, no wrong way in, whether you come through your housing association, whether you come through citizens advice, whether you come through a mental health charity, whether you come from a mental health ward, no wrong way in. We will wrap care around you, and we will try to keep you as far away from escalated crisis services as possible for as long as possible. Mental health has got a lot of those examples, and it's an obvious one where housing and advice and advocacy and clinical services and education services need to work together, and this is happening. Lambeth, where I live, has got really interesting co-commissioning models, again, for people living with relatively severe mental health, often at the back end of an inpatient stay. It is much cheaper and it works much better.
Thank you. I would just add one thing. So as a concept, I think it's very exciting. And Charlotte has outlined, how it has worked, and we've seen some great examples. The one point I would say is what's behind it, and what's your motivation, and what's the exam question? What are you trying to do? What are you trying to solve? And I would come back to, is it truly about co-production, and is it truly about fairness, compassion, kindness, the right care, right time, right place? And if you're really wanting to engage with our communities and the people we serve, go for it. But the first question is, I'd ask, what's behind you going down that route?
Lovely, thank you. Is there a model that would help embed co-production into day-to-day work in healthcare organisations? Who wants to start with that question?
Well, I will, because I don't know the answer. And I think if there is a model, I want to know it. I'm not so there are lots of different ways. Let's think about it that way. And I think so there are lots of different models, if you like, and many have been tried. And I suppose you need to be sensitive to the people you are serving and the people you're talking to and the people that you are working for. Actually, also, I think what's really important is the maturity of your organization in this space. Really, it's an ambition, it's hard work. You have to be in touch with your own vulnerability as an organization in order to do this properly. So you can't have somebody suddenly turning up and saying, this model, and we're going to do this, if the organization isn't ready. And so be careful not to set ourselves up to fail. That's what I think, Charlotte.
The way we try to roll these things up at National Voices often, and we often sort of synthesize the evidence and the experience and the insight that our members bring, who are obviously all much closer to people and communities than we are. We are sort of an umbrella organization, if you want to call us that, is that we say it needs to happen at the level of the person delivering a service, so the person who actually sits with the patient. It needs to happen at the level of service design. So, the people who design how to run this outpatient clinic, or how to run this diabetes clinic out of primary care, or how to run this young people mental health service or whatever. And then it needs to happen at the system level. And I think that's also what Navina was saying. If these things aren't aligned, then people can expend a lot of energy and find themselves floundering and bumping against obstacles. So if the primary care practitioner starts their consultation with the person walking through the door by saying, what matters to you? So you've just described to me that you're breathless and fatigued and anxious. What matters to you? Then the answer to that has the potential to totally destabilize how we deliver primary care, because it might transpire that what this person actually needs is connection and purpose, and that they need peer support, and that they need help with their housing, and that they have a violent husband. So it's no good asking the question if you're not ready for that, for that grenade to go off, in a way, because the way we have configured the service works for the service. It doesn't work for the problem of the people who are quite substantial users of health and care services. And I think system leaders, and that's I'm hoping where the population health management movement is taking us, system leaders have a responsibility to interrogate the data, I think, about who is not well served by the way we design care around here. So who's not being helped by the way we organize eating disorder services? Who's not being reached by the vaccine program? Who is waiting the longest for elective care? We need to disaggregate the data. That's the role of system leaders. And then go to those communities who are currently not well served and say, what matters to you? What do you need from health and care services? So I think the temptation is to talk to the people who are in the service, and they're the people who are already more successful at getting the health outcomes that they require.
Thank you. That's really helpful. And I think, again, a question that connects quite well to what you've just been talking about is, should co-production be a core competence for NHS patient-facing staff? And I feel like you've touched on this already, but there could be a little bit more to develop there. Who wants to start?
Navina, I feel that's one for you.
Okay, so I think it, of course, it should be. All right, that's the starting point, and and we have to acknowledge it's so obvious, but it's hard, and therefore we need to put some energy into making it so. And I know that when we try to do that in our organization, some of the reasons people would come up with, good people, fantastic clinicians, would come up with all sorts of reasons why it couldn't be possible. It's really interesting. So we need to listen to that and then try and understand, what is that about? Where's that coming from? And then how do we support people to see the value of it and make it so? My fear about core competencies and skills is that we have a tendency to beat people up when it's hard or they don't get it right. And then it becomes something to be even more afraid of, or or that it becomes a tick box exercise. But that's not to say that's not a reason for not doing it. It's to be aware of it. So I quite like that idea. And I guess in Health Education England, I'm thinking, that could be something we have actually got the span and the reach to think about. So yeah, thank you for that suggestion.
The only thing I would add to that is where a clinician or a frontline staff, I don't really like the language of the frontline, let's call it the point of care, where the clinician, the health professional at the point of care, takes on what matters to the person in front of them, they often then bump into their own powerlessness inside the health and care system. And I think it's no good insisting that people need to have that skill of co-production without then also acknowledging that they need the support to take what matters to people into the health system. So, like a real life example, my husband David was very ill with cancer, and he, towards the however many sessions of chemotherapy he had, towards the end, what happens very often is that people need a lower dose of chemo drugs because they're already very poorly. And so you have a blood test and it says, oh no, we need to reduce the amount of chemo drug we give you. And so the script needed to be rewritten for his chemo drug the morning of his chemo. And the nurse who was leading the chemo ward, very senior nurse, could not get hold of a consultant to rewrite the script. And the pharmacist was not empowered to write a script that was a lower dose script than the one that was originally written. And so we sat there for hours and hours and hours and hours and getting quite distressed and angry and upset because he was very ill and he was very tired and he didn't have long to live, and this was really not how you wanted to spend your life. And I said to the nurse, this must happen every day. Very senior nurse, this must happen every day that someone needs a new script writing. Why don't you have a way of dealing with this? And she said, yeah, I know, well, maybe you could make a complaint. And I think it's that, isn't it? That even when a health professional is listening to a patient, we then need to redesign how the health service manages itself so that the person who has understood something about patient need can actually make something happen about it. And doesn't say, oh, can you put a complaint into the system? To which my response was just, my husband's life expectancy is going to be measured in months. I'm not going to waste my time putting a complaint through your ridiculous systems. So I think there's something there about supporting people to do it well, not just demanding that they do it.
Absolutely. There was a question that I think I'm going to take that somebody's asked, should we have invited folks or patients or charities who routinely advocate, like Citizens Advice or Shelter, to talk today to get feedback from the coalface, so to speak. And we are inviting people with lived experience to future webinars with more specific focus, just to make it simpler to identify the right group of patients, people to bring in. I think we've only had an hour today and it's flown by. So I think to make sure that all of that engagement is meaningful, we want to make sure that we're doing it in the right way. But one of the points behind co-production is to blur the line between patient and provider, and making sure that we are co-creating. So we need to remember that we are all at some point going to be using healthcare systems, and for those of us in healthcare and public health to bring those experiences with us as we work, rather than compartmentalizing the two. So one of the things that you said, Navina, was about not separating yourself from the work that you do. And I'm really aware of the Bring Your Whole Self to Work campaign from Mental Health First Aid England. And I think that's been really helpful, and thinking about that feels really key when we think about co-production and trying to blur those boundaries. I'm aware, certainly in previous roles, often there's been service user groups or service user voice that's then been separate from the expert or the professional voice, and that's not something that we really want to encourage. So it's really thinking about how we bring all of that together. So I hope that covers that question. So in the sort of last few minutes that we've got, I'm just going to come to each of you just for your take-home message. So if there was one thing that you were to ask people to really reflect on and take home today, what would that be? So you're nodding readily, Navina, so I'm going to come to you because it looks like you might already have that answer.
This is so important. I think that my take-home message is one that I mentioned earlier. It's a movement. I think and the more people that join the movement, and the more we talk about it in as many places as possible, and make the links with everything that we do, every single thing that we do in health and care, to the experience of the person we serve. So I think that I'd love to encourage more people to join this movement. Thank you.
I think my if I could only say one thing would be, you might think you're too busy and that there's too many pressures on the services and that there's not enough people to do this, but not to do it is the definition of wasteful provision of services. So providing services that do not meet the needs of people because you haven't understood those needs is the definition of providing really low value services. So one thing you can't do if you haven't got enough people and enough time and enough resources is continue providing really low value services. So we can't not afford not to do it.
Lovely, thank you both. Really appreciate you giving up your time today to join us and to share all of that insight. As you've said, Navina, it is a movement, so I hope that people are inspired by today's session and are able to move forward with that. And there's some really good resources shared by some people in the chat as well, so I think that's helpful, and a few people have said that it's been a really useful insight today, and there's been some great ideas, so hopefully we'll all be able to build on that. And as we say, there's no blueprint for co-production. There are lots of principles that we've covered today, and we hope that you're able to take those forward. So in the last minute, I'd just like to remind you that we have got another session, so a webinar on the COVID vaccine myths and disinformation on the 14th of July. That's at 12:30 to 2 o'clock. So if you are interested, then please do join that. And just in the last few seconds, I want to say thank you very much for joining us today, and let's continue this conversation in the future. Thank you, everybody. Thank you. Bye.